Alright guys, welcome to the Lifeproof Core Series Day 3. We will get right into it here, on to the next slide. So to recap the previous days, so remember day 1 we went over a lot of concepts that were going to be used and applied as we progress through the course. And a lot of those concepts should be coming up last session and today, so I want you to kind of keep an eye out for those. Remember, we talked about pain science, we talked about the joint by joint approach, we talked about tensegrity, we talked about the length tension relationship, we talked about last week how mobility restrictions, why they might alter your ability to move or facilitate movement compensation that could cause pain or inefficient patterning of movement. And again, the tensegrity joint by joint approach, that's kind of how you would explain it all. We also learned last session how to actually work on your mobility and how to improve your range of motion. And one of the big tools that I use with most all of my clients is myofascial release and self-myofascial release. So it's similar to what a manual therapist might do soft tissue wise with their hands, but you get to use tools and do it on yourself, which is very, very powerful, because if you do want to improve your mobility, it takes time. You have to work at it daily in order to improve that status. I'll tell you firsthand that if you don't do it daily, it will not get better. PNF stretching, it's another style of stretching. It's a contract relax method. Again, kind of getting at the nervous system, just like myofascial release likely is working. We didn't go over any techniques with that last session, but you can look those up on YouTube if you'd like to experiment around with those. And then the hip 90-90 is working. It's kind of a static stretch, but you're really working on the hip capsule of the hip joint and trying to get those tissues to articulate a little better and to move a little better. So just be careful. I know today in class some people mentioned that they were pretty sore after doing it. It can definitely be the case. If you're somebody who did react pretty intensely to that hip 90-90, I want you to tone down the intensity of your stretch. Everybody's a little different. It's hard to say, if you're going to respond intensely or not. But now that you've done it once, if that was you, definitely take it down a notch. You do want to stretch. You don't want to get into an uncomfortable position, but you don't want to overdo it in that regard. So I just mentioned that myofascial release takes some time, and mobility retraining takes some time. I want to now move on to the next slide to show you my own personal journey with mobility restriction. As you can see here on the left side, this was in June of last year. That was my active straight leg raise. So we went over the active straight leg raise last week. And remember, you could be limited by a trunk stability issue where your pelvis isn't stabilizing so that the hip has a nice foundation to work off of and the hamstring length is optimal, versus if you didn't have that, your pelvis might arch forward, hamstrings would lengthen, you wouldn't be able to get the hip up high enough, and the hip musculature would be acting off an unstable base, further decreasing the efficiency of that movement. Now, if you have a complete mobility restriction during your active straight leg raise, which is the case that you guys are seeing here, my leg physically will not get up further. On that left side, it will not get up further than it's going there. So if somebody came and tried to crank my leg up, I would have to compensate, or I might get injured if they did it with enough force, right? So that should get the brain rolling a little bit to say, okay, what's going on here is I've got some posterior chain tightness, right? I can't go into hip flexion very efficiently, and once I get to this point in hip flexion, I stop. I can no longer go further and maintain a neutral spine. So we talked today about why that was potentially causing or a contributor to my own back pain a year ago. Was that when I went into a hinge, or if I was bending over from the hips, I could only get that far. If you took that picture and put it on its side so that I was standing up, I would only be able to get that far into a hinge. If I wanted to hinge and bend any further, I would end up rounding through the pelvis and the low back, rounding through the thoracic spine, and bending, putting a lot of pressure onto the discs of my spine, bending over and lifting something, potentially with a lot of force, because I was doing deadlifts and things at the time where that was a big player in my back pain. So that second picture there now is 2 months later, so August of 2017, and that marks a point where I was doing daily mobility work for 2 straight months, meaning I didn't miss a day. Maybe 1 or 2 here and there, but I pretty much did it daily. And you can see the great improvement. You can see that stick there for scale. So definite improvement. After that August picture, I didn't monitor it quite as closely, and I stopped taking pictures. But actually, this was yesterday. The date today is June 30th. This was June 29th that I took this picture here on the right. And as you can see, awesome improvement, right? On the FMS, we use a 0, 1, 2, 3 scale, 3 being the absolute best, 2 being adequate. In my first picture, I was a 1. In my second picture, I was still a 1, but I was much closer to a 2. In my third picture, I would probably qualify for a 3 there. And that took time. What it took was habit building. I stopped thinking about it so much after August in terms of actually monitoring my progress, but what I was still doing was I was still including mobility into my daily routine, especially before I was working out, and as much as I possibly could. And I built those better habits. And as a result, I was really happy to see this picture I took the other day to be able to go into almost 90 degrees of hip flexion, which drastically improves my ability to bend and to go into certain positions that require hip flexion and not experience a physical inability to do that task, where then it would come down to more of a motor control, control of that position to do it correctly. So I'm hoping that this motivates you guys to see how this stuff can change and move. Your bodies truly can change if you work at it and you build those good habits. So on to the next slide. We're going into our next movement dysfunction. So remember, we started number 1 with breathing, because that is the movement that you do the most, and it doesn't, it isn't all that altered by mobility restrictions. There's a little bit going on that could potentially alter the way you breathe, but overall, if we produce or practice a nice belly breathing pattern, we're generally going to be better off than without it. The second movement dysfunction that we talked about was mobility restrictions. And the reason we talk about that second after breathing is because I can't teach you how to move better, how to rotate better, how to practice better trunk stability, how to squat better, lunge better, walk better, all those things, if you have mobility restrictions that are holding you back, meaning the joints just won't go in the positions that we want them to. So, and our next movement dysfunction is rotation. Okay, so we have these, we talked about fascial slings or the anatomy trains. Remember that Tom Myers kind of coined that term, but talking about how fascial lines can be tracked all throughout the body. And those fascial lines generally work together to produce specific movements. And you have these fascial rotational slings as well. So you can see on this picture here on the right, the anterior oblique sling that's on the guy facing forward, running from his obliques down through the abs, through the opposite musculature, the anterior hip, so hip flexors and things like that. And then on the right, you've got the posterior oblique sling running from the lat down through the QL musculature, crossing over into the right glute and down through the leg. So those slings have responsibility in rotation, and they have responsibility to produce rotation, but also probably even more important is they have responsibility to stabilize rotation. So there's a huge demand on the body rotationally in the transverse plane that we don't really realize. A great example is your gait cycle, which is walking. So if you, walking, running, things like that, if you are leading with your left leg, you're stepping with your left leg, your right arm is swinging forward and your right shoulder can kind of close toward the left hip. That is using that anterior oblique sling. Conversely, the posterior oblique sling on the opposite side, so if my left leg is going forward, my right arm is going forward, that left posterior shoulder, the lat, down through the right oblique are also being used at the same time. So those two slings synergize together in the gait cycle and in any rotational movement to produce rotation and also to stabilize rotation. So if we're trying to prevent rotation, I don't know if you've seen people that run and their hips are kind of rotating all over the place and their trunk's kind of staying still, and it looks like they're running 2 miles to the sides and 1 mile forward. That's an example of somebody that doesn't have good ability to stabilize rotation. If you are, let's say, picking your groceries up out of the car. Let's say you had one bag and you picked up that bag to walk it in. If all of your musculature just turned off, you would probably fall to the side and rotate a little bit, right? So walking with something in one hand is a great example of a requirement of stabilizing rotation, right? You don't want to let that thing rotate your body. If you're walking, say, with two bags, and one bag is heavier than the other, that is another example. Basically, what I'm getting on here is life is asymmetrical for the most part. We rarely get to load our bodies symmetrically and move symmetrically because that's just not how things work. It's funny that in the gym settings, we tend to do that a lot. If you're doing a deadlift, you load the symmetrical bar with symmetrical weight and you stand right in the middle to lift it up. Same thing with the barbell squat. Same thing with all these other movements. And that's why functional training or functional movement has become more and more important and also more and more of a hot topic, because basically the premise is you're training in more of in a way that's going to prepare you for life. Right? It's going to train you to improve and perform better with daily tasks, and a lot of that comes from asymmetrical loads and working in the transverse plane and things like that. So rotation, very important in class. And then why it might affect back pain is that, remember, that pelvic lumbar spine region in the joint by joint model likes to be stable, right? It would prefer to stay stable, and a lot of the motion would prefer to come from the hips in rotation and from the thoracic spine. So for one, if you have a mobility restriction in the hips or thoracic spine, that can cause the pelvis lumbar spine to need to move more to create rotation, which we know the lumbar spine doesn't necessarily like. Furthermore, if your rotational slings, those musculature slings, aren't being activated and engaged by your brain efficiently, then you may also get excess movement. Remember, with stabilizing rotation, then if the problem is your body's being put into rotation that you don't want, or that you're not necessarily trying to do, and the reason being is you can't control it because the musculature isn't doing its job, then again you can get these shearing effects across the and rotational turns of the lumbar vertebrae that maybe don't necessarily want to be there, and that then you can put excess pressure on, say, nerves coming out of the spine, on discs, joints, things like that, that can cause issues and potentially cause back pain. A lot of the times people have single-sided, or it hurts worse on one side of their back. And almost every time somebody comes in with that into my clinic, I see that they have rotational dysfunction. So that's usually a major player. So the screens that you guys did today are a standing multi-segmental rotation screen, and that's standing tall with your feet together, toes touching each other, not letting your feet move, and then trying to turn as far behind, rotate as far as you possibly can to look behind you. And if from the vantage point of somebody standing behind you, if they can see your opposite shoulder as you turn, if you're turning to the right, if they can see your left shoulder pop up on the outside of your body, then we say that that is adequate multisegmental rotation. If they cannot, we say that is not adequate multisegmental rotation. Remember, that's implying that you have enough range of motion at your ankle, at your hip, and at your thoracic spine to be able to do, and also that you can recruit the musculature and have good active motor control to produce that movement. Very common for some of you guys to be feeling cramping sensations through your obliques and maybe potentially low back, things like that. That is a good sign that we are not being very efficient with our rotation. Usually it's that the sling isn't working, quite well. You're not coordinating the right things at the right time, and something else is trying to take over because your brain knows it wants to produce that rotational movement, but it doesn't really know how to get there efficiently, so then it tries to recruit other things that end up cramping. And then the second, well, I guess the first one there is the rolling screen, and that is from the ground, and that's a really cool both screen for rotation and motor control corrective for rotation. And as you can see in this picture down there on the right, it's got somebody laying on their stomach who is then rolling onto their back, and the key there is you cannot use your lower body to kick off. That motion should come all from the head, moving with the eyes, the arm moving, and the trunk rotating. Okay, so you need to go, you're going to get down on the ground, you're going to try to roll in all four directions. You can roll from your back to your stomach, from left to right, and you can roll from your stomach to your back, from left to right. Okay, and that is using those four slings, rotational slings that you see in that upper picture, right? Anterior oblique slings, both cross patterns, and posterior oblique slings, both cross patterns. So sometimes you'll have asymmetrical dysfunction where you can roll okay in one direction but not the other, or you can roll okay from stomach to back but not from back to stomach, different things like that. So you're going to screen yourself and determine if you've got any rotational dysfunction. So moving on, now we're going to use that same rolling screen as a corrective intervention. Okay, it's going to become, the screen becomes the exercise. So, like I mentioned, you got four directional patterns controlled by these rotational slings. You should be able to roll without using legs or momentum. So if you felt like you needed to kick off the ground or lift a leg, right, that would be a momentum swing or a push off that would help you get over, that's not using the upper body. So we're trying to completely take out the upper or the lower body from the equation. In class we watched somebody roll, right, as a screen, and we saw their leg from their back to their stomach, and their legs were trying to, especially one, was trying to lift up off the ground, and that kind of shows you that it was following that same sling pattern from right chest down through oblique into the left hip. Remember, and she was rolling from her right to her left, and as she was reaching the right arm, her left leg wanted to raise up and close off that sling. So what we know from that is that the arm and the head were able to move, but then that middle section, that section through your trunk of the sling, probably wasn't being engaged or efficiently or coordinated engagement, so that something down the line, a big prime mover muscle of that sling was trying to take over and go, I will help you out, let me engage there. You can relate that to walking, right? If you stood them up and they're walking their gait cycle, likely that core isn't contracting, engaging, and stabilizing rotation efficiently, but the big prime mover hip flexors are, and the arm is, right? So anyway, so this intervention was developed based off of human developmental patterning, how we develop our movement in relation to our environment. It's one of the first things that an infant learns how to do is they learn how to roll over in their crib. And if you watch them roll over, it is very smooth, very efficient. They don't look like they're cramping up, they don't look like they're hitting a wall, they're not trying to swing, kick their legs, right? They learn how to do this very efficiently because they're adapting to their environment. Somewhere along the way, a lot of us have lost that ability to rotate efficiently. Probably the sedentary lifestyles we live. Then when we need to rotate, we don't know how to do so. So you're going to do this as a corrective intervention now, and you're going to learn and try to get your body to roll more efficiently. In class, we used a partner assist, so you have a partner who's going to give you a little push. If you're going from your back to your stomach, they're going to give you a little guidance from that shoulder that's leaning over to get you over so that you are challenged but successful. Remember, that partner is going to use just enough pressure on the shoulder to get you over but still make you work a little bit, right? Just so you don't have to compensate. If you don't have a partner, you can lift yourself up on some pillows or some type of lift so that you're starting further rolled over in that, rolling pattern. So you'd put it under one side of your hip and shoulders to kind of prop you up. And you'd find a height where, again, you can be challenged but still successful, to where you kind of have to work, but you can do the roll without compensation. The problem arises with correctives if you don't find that magic challenge but successful zone, and you are instead challenged but failing every single rep. If that occurs, your brain is not going to comprehend that the failure, it's going to think the failure is actually a success. It's going to think that that's what you want to do, right? But we want to clean up that movement and get you the actual success, which is correct rolling, and you got to be a little bit challenged to get there. So you guys are going to work on that. You're going to be adequate at rolling hopefully by next week. If you work on this a couple times a day, it's possible to get there. It could take a little bit longer. It could take a couple weeks as well. Next slide. Our next common dysfunctional movement is trunk stability, and that can also be talked about as pelvic tilt. So you see this image here on the right, and we've got a neutral pelvis, which technically a neutral pelvis is slightly anteriorly tilted, so that flat line running across the top of the pelvis isn't entirely correct, but it gives you the idea. That next one over is an anterior pelvic tilt, so that right side is the front side of the person's body, that's their stomach, the left side is the back, those are the glutes, low back you see there, and they're rolling the pelvis forward so that the lumbar spine, low back arches, right, and the belly kind of sticks out there. And you can see now that trend line of the arrow running at the top of the pelvis is tilting downward. Okay. Furthermore, when this happens, you end up getting a rib flare, right? So the lumbar spine flares and the ribs kind of hike up in the air. And if you drew a line at the bottom of the rib cage, it would then point upward, right? Versus the neutral pelvis, they'd both be fairly horizontal. We talked about this, right? That anterior tilt then affects the whole rest of the spinal column. Then you've got this big lordotic effect, or big arch through the lower back, all the way up through the thoracic spine. Cervical spine can then be altered as well. Okay, we won't talk so much about that section. The other thing, breathing, right? We're taking it back a notch to day one. Breathing, this is what gets facilitated when you breathe incorrectly. When you breathe through your chest, you get the rib flare, you get the anterior pelvic tilt, right? And then that's why we care so much about breathing, is because it puts you into this postural deviation and it facilitates it. Okay, the belly breathing facilitates that neutral position over there on the left. Then you've got over here on the far right a posterior pelvic tilt. So this happens with some people as well, is that they go backward instead of forward, right? And in this position now, then you've got excessive curve going the other way. Instead of an arch, you've got the opposite curve through the lower back. That affects the whole spinal column going up, and that can cause issues as well. So if you look at the spine when it goes into anterior or posterior tilt, it can put excessive pressure in anterior tilt on the joints of the spine. A lot of people get facet joint issues, SI joint issues from an anterior tilt. Those that posterior tilt can get disc issues because spine's putting more pressure onto the discs. So you get bulge disc, herniated disc, things like that. Pelvic tilt can be kind of a postural deviation. It can be just your brain has turned that into new normal. whether that's being driven by a mobility restriction or a motor control restriction, right? That's something that you got to kind of figure out. But a lot of people tend to live most of their lives in one of these two postural deviations. That can be a big issue, right? If you're in posterior tilt, you're almost always putting pressure on the discs, right? You can't even get out of that posterior tilt. So the discs are just consistently getting excessive pressure. And then you apply a lot of force in specific movements, like say you're doing a deadlift, and then you put a lot of force into those discs, and you can have an acute injury of like a ruptured disc, or over time those discs can bulge and herniate and you have issues there. Same thing with the anterior tilt. If you're there constantly throughout your day, throughout your movements, you can have issues with the joints. It is also possible to have disc issues in an anterior tilt, especially if you tend to hinge from one specific vertebral connection. A lot of the times that's L5S1. Okay, and if we're not able to segmentally move the spine, you get this movement across that joint consistently, putting a lot of pressure down through that joint. Whereas if you could move subsequent joints up the chain to help with extension or flexion, then those joints in turn would help take some pressure off that specific joint. Okay. So, pelvis alters the entire spinal column. Then I put this next thing in there to just get you guys thinking about how all this stuff is starting to work together, all these concepts that you've been learning. Length-tension relationship, right? Kind of on the performance end says that the muscles can't contract efficiently. If you're in posterior pelvic tilt, I used the example in class today, that was me, that was my issue. My hamstrings were so tight, so I had a mobility restriction pulling me into posterior tilt, meaning my glutes were then shortened, right? I didn't have a very developed butt, right, or glute musculature, because they were constantly shortened. They couldn't get lengthened. They couldn't get back to a neutral position if they wanted to because the hamstrings were pulling them down, nor could they get into very good anterior tilt. Therefore, those were shortened. I couldn't create solid glute contraction and move it through the full range of motion, extend it and contract it to build glute musculature. So if you're looking at the performance level, right, I wasn't able to efficiently use my glutes, meaning my movements were then less optimal, right? If I was an athlete, right, I couldn't drive off the glutes as well. And furthermore, I couldn't build glute musculature very well if I'm looking for the appearance aspect. And then there's the tensegrity concept where, in my example, tight hamstrings, like tight fascia, can pull up or down along the chain of the posterior line of fascia, and that can alter and give you pain in other areas, right? And then the joint by joint approach, where my hips, right, they need to be able to move, and the hip joint needs to be able to move, but my pelvis was kind of locked posterior. The hip joints didn't grant me that range of motion that they needed. Therefore, I was putting excessive torque across the lower back, causing it to move more than it would like to, and excessive stress there that was probably causing my pain. So, this last little note, motor control inherently is affected by mobility. So, again, if I'm locked up mobility-wise, then I cannot learn how to efficiently use my brain to control my body because my body just won't go there. So the screens you guys are doing in class, you've got a trunk stability push-up and just a standing pelvic tilt. You're going to stand there and you're going to put your hands on your hips and you're going to see if you can tilt and arch your lower back, but tilt your pelvis forward and tilt it all the way backward or round your lower back, to see if you can do that without recruiting other muscles and other joints. When you posterior tilt, your knees shouldn't bend, your ankles shouldn't dorsiflex. When you go into anterior tilt, your knees shouldn't excessively extend, and your thoracic spine and your neck shouldn't compensate for it. Okay, you got to get that good motor control to be able to move just the pelvis. The other screen we're going to check is your trunk stability push-up. So that's going to be a push-up with your hands kind of right under your chin, and well, the crease of your thumb in line with your chin and your armpit. Okay, so you should be able to press up off the ground in a push-up without your, well, basically with your whole body rising at once, right? It shouldn't appear as your chest rising, then your trunk and hips rising. That would suggest that your body isn't able to maintain a neutral pelvis and a braced core so that everything rises at once. So you're going to check that out. See how you do. The big indicator there is, does your chest rise before your hips rise, right? If you can do all that simultaneously and get off the ground, probably doing okay with trunk stability. And then the last thing there is that trunk stability push-up does have a strength component, so chest strength and tricep strength needs to be adequate in order to produce that movement. So it is, you know, it does happen where somebody maybe has good trunk stability but doesn't have good chest and tricep strength, and that's more so it limits that pattern. So from a trunk stability standpoint, it's possible that, you know, they're still okay. But most of you are going to find, in fact, today in class, most of you, I think all of you, did have, you know, weren't able to recruit the core and stabilize the pelvis lumbar spine in that fashion. So moving on, we've got our next corrective intervention for trunk stability. And what this is all centering around is segmental motor control of the spine. These three interventions. We have to be able to move each segment of our spine, meaning we've got to be able to tilt our pelvis in full ranges of motion, arch the lower back and round the lower back in full ranges of motion, arch and round the thoracic spine, full ranges of motion, and arch and round the cervical spine or the neck in full ranges of motion. So you can see this picture here on the right. The model is arching in full extension, anterior pelvic tilt, full extension of the lumbar, thoracic, and cervical spine, and then full posterior tilt, fully flexing the lumbar spine, thoracic spine, and finally the cervical spine, neck. So we watched me do this today in class, and we watched how I was able to move my pelvis to its maximum range of motion and then start to move each vertebrae at a time, right? If I was going anteriorly into extension, building extension through the thoracic spine until I hit my neck, and then fully extending the neck. Okay, so you guys are going to go very slow and try to work. Think about each vertebrae moving one by one as you get there. Okay. Then, so that's moving your entire spine. Then we've got to learn how to just move the pelvis, because a lot of people, when they do these cat-cows, they, you know, say on the far right there, they go into flexion, but they're really getting a lot of flexion out of the thoracic spine, and then they didn't even realize that their pelvis and lumbar spine could have posteriorly tilted and flexed a little bit more. So you're going to work on a supine pelvic tilt that's going to give you a lot of feedback because your entire back is on the ground, and you're just going to do just movement of the pelvis. So your thoracic spine and your cervical spine are going to stay static, meaning they're going to stay flat on the ground and not move. And then your lower back is going to arch off the ground and push into the ground by moving the pelvis. Okay, and then you're going to take that up back into the quadruped position, which is that cat-cow setup with on your hands and your knees. And then from there, you're going to stabilize your thoracic spine and cervical spine. I would look in a mirror for all this stuff so that you can see and get some visual feedback. Thoracic spine, cervical spine stay static, and your pelvis rotates forward and backward into full ranges of motion. Okay, so that's where we ended today. So by next week, you need to be able to breathe through your belly diaphragmatically, add tension to your system and still breathe through your belly. You need to be able to understand if you have mobility restrictions and how to fix them using foam rollers and stretching techniques, and start to work on those. Remember, those can last, those can take a long time. We saw the picture of my progression. Okay, you got to build those good habits though to get the ball rolling. You need to be able to now, from stuff today, Understand if you have rotational dysfunction, and everybody in class today, I believe, had some type of rotational dysfunction. We need to learn how to start recruiting rotational slings, and the exercise you're doing for that is the rolling exercise. Then you need to understand if you have some trunk stability issues, right, which maybe are driven by a mobility restriction, which would mean that that needs to be corrected first. If you are like me and you have really tight hamstrings and glutes pulling you into posterior tilt, then you've got to mobilize that before we can teach you how to stabilize it. If you have good mobility, then and your issue is stability, then we've got to learn, okay, do we tend to exhibit more anterior tilt, posterior tilt, or both? Right? Do we have trouble just keeping the pelvis in one place? If you do, then we need to be able to move our pelvis and spine so we understand your brain can put the pelvis into the position that we want it to set up the spine for success. If we don't have that good motor control to be able to move the pelvis, then we cannot properly teach you how to stabilize and search for that neutral position through most movement, which is what we're going to do next time. Okay, so next time, more things are going to build upon each other. We're going to learn how to then strengthen, find pelvic neutral, then brace the core, then breathe through the core through exercise to build strength and endurance, and then use those same mechanics into more functional movements like squatting and lunging and walking and running and all that sort of stuff. So day 4, the accumulation, that's coming up next Saturday, so make sure you guys are there. I look forward to seeing you all. Have a great day.